I'd like to acknowledge the local custodians of the land in which we meet this evening and honour elders past, present and emerging. I'm Melissa Wilkinson from the Hunter New England Central Coast Primary Health Network. Welcome everybody tonight. We're here for youth mental health and its impact on general practice, and that is a really current topic. It's a really important topic, and I want to thank you all for being here with us tonight. I'll just go through a little bit of housekeeping. We are being recorded tonight. A copy of this will be available in the coming days in our education library, along with a copy of the presentation as well. There will be a poll as per usual at the end, and I strongly encourage you to please complete that. It only takes a couple of minutes, and we base our future education events on that feedback, and it's really nice for the presenters to get that feedback as well, and to be honest, we get some beautiful feedback from you all, so it's very much appreciated and it's very helpful. There'll be a Q&A at the end of this session, so if you have any questions, now's your opportunity to pop your questions into the questions box, and I'll read those out for the presenters at the end. So welcome Michelle, Erica and Olivia. Welcome to you all, and thank you for being here as well. And it gives me great pleasure to hand over to you now, Olivia, to do your presentation. Thank you.
Thank you, Mel. Thank you. Hi, everyone. Thank you very much, especially all the wonderful nurses that have registered for this event. Look, my name is Olivia. I'm a clinical nurse consultant. I work for the Central Coast Local Health District with the Child and Adolescent Mental Health Services in Gosford. Why I'm doing this presentation has been in the back of my mind for a long time, basically for support for the registered nurses, for the practice nurses out there that are the front line, that are providing all the first line care for the clients, consumers, young people, and also being there for the GP. I've done a few presentations for GP, but I thought now is time to just give some support for practice nurses and to look after you and make sure that you guys are well supported by people in the health service. Tonight's topic is about physical health and linking it with the mental health, especially around the young persons. As mental health clinicians ourselves, we always put the physical health on the same par as the mental health. Why do we do this? When we start with a new client, we get the first point of contact with the client, we always look at the physical health. The first thing we do is we ask them for the weight and the height, and then check with them just basic physical health. Sometimes we do physical obs, sometimes we don't. It's really important before you look at any mental health symptoms is to look at the physical health, because sometimes mental health can be a consequence of physical health. So again, as practice nurses, you're first front line, you're the first point of contact with the client, with the patient. You're the ones who will do the physical obs. You will look at the path results. You will sometimes even listen to these people while they're talking, maybe about situations, about stresses, about things happening in their life. That's really important for you as nurses to feel that you are supported and you have a little bit of information that can help you link physical health with mental health. So why is physical health so important? Part of New South Wales Health is that we have to look at the physical health, because understanding physical health, looking after physical health, that will give us better outcomes of care when we are partnering with our consumers as per standard 2 of the clinical nursing. When we are linked with when we have a client that's joined our service that has a lived experience of mental health, we have to offer them some support around interventions that are related to the physical health. Part of our job too is to be able to link with the private practices, link with the practice nurses or the GPs and say, okay, these are what we've discovered as far as physical health. This is what you as a GP and as a practice nurse can contribute to that consumer and help them. This way we have this partnership with the private practices, and through this partnership we develop pathways that we can look at physical health and mental health. Why is it important to look at physical health when you are looking at a mental health presentation? Research will tell us that most of the consumers or clients or patients that have a mental health illness have a poorer health outcome than a person that doesn't have a mental illness. They have shorter lifespan. They experience stigma. They experience discrimination, multiple presentations into hospital, multiple presentations to the GPs, and then multiple presentations to the primary care providers. This particular group or cohort of this population, they are the ones that need our support and need our partnership with the primary care provider, the GP or the practice nurse, with the family, and with the mental health services. 4 out of 5 people that have a mental health experience have a coexisting physical illness. People with depression, usually sometimes it becomes co-linked with cardiovascular diseases, diabetes, metabolic syndrome, and respiratory diseases, cancer, dental. These are all the type of physical illnesses that are always linked or can be linked with a mental health component. Consumers or population of mental health clients in the general population usually have a life expectancy 14 to 23 years shorter than a comparable person without a mental health illness. 2 to 3 times more likely to have diabetes and 6 times more likely to develop a cardiovascular disease. 50% of the population, the mental health cohort of clients, are smokers. So you can imagine all the illnesses that are linked with the smoking: COPD, elevated blood pressure, diabetes. All these things are a bigger component of it. Who are the populations that are most affected by physical health and mental health? Our Indigenous, our Aboriginal population, the older persons, and child and adolescent. And we see that a lot within the cohort of the clients that come to us, the child and adolescents from 12 to 18. Those also with the first presentation to a mental health service, those with the first episode of psychosis, or those with the prodromal presentation. When we talk about a prodromal presentation, I'm not going to talk much about it because my colleague Michelle is going to go into it in depth. When our symptoms are emerging but are not yet fully present. So we can say prodromal symptoms of schizophrenia means there are some indicators there, but they're not yet at the diagnostic stage. They're not yet fully diagnosed. People from culturally and linguistically diverse backgrounds have problems with communicating what their concerns are, whether it's physical or mental. Sometimes the cultural beliefs play a big part in people recognizing that, yes, there is a mental illness here and there is a physical health component. Again, also the LGBTQIA communities, these are quite highly impacted by physical health and mental health. So what do we do as mental health clinicians what physical health screening do we do as mental health clinicians when we at the first point of contact with a new client? We look at lifestyle factors, especially, the age group between the 14 and the 18. A lot of them are smokers, they vape. What's the physical activity levels? Are they sitting playing computer games and gaming online all the time? Are they going out? Are they doing any physical activity or not? What's the diet like? Is that diet all takeaway foods, high level fatty foods? Are they eating adequately? Are they having enough hydration? What's their sleep like? What's their oral health like? So these are all things that we look at when we have first point of contact with the client. We also look at weight and height. What's the BMI? What's the waist circumference? Especially again when it comes to those presenting with first episode psychosis. As practice nurses, you will get a lot of these younger population, maybe 17 and 18, that are presenting with first episode psychosis. You might know it is first episode psychosis, you might not know about it, but it's really important then to focus on the physical health and to make sure that the physical health is well covered and under control. What's the fasting glucose levels? What's the random BSL, HbA1c, blood lipids? bloodborne viruses, polypharmacy, illicit substance use. Usually when I get a referral from a GP for a young person, I'll usually call the practice after the assessment, ask to talk with the GP and say, doctor, please, can we have a full organic workup for this young person? That's very helpful because then the GP's got a baseline and we have a baseline too, and we know exactly what is happening with this young person. Why do we do metabolic monitoring for consumers of mental health or mental health people with the lived experience? Some of the mental health consumers are on what we call psychotropic medications, antipsychotics, whichever way you want to refer to them. We usually will do metabolic monitoring as a routine, cardiometabolic risk at 3 months, then at the first 12 months, then at 6 months intervals thereafter. As practice nurses, you're going to be seeing these clients for long term. We will see them for a short period of time, most likely around the 2-year period, especially those with first episode psychosis. We'll hold them for around 2 years, and then we will usually try and get the GP on board before we discharge them. So this is what we need to look at. If they are on depot, if they are on oral antipsychotics, if they are on antidepressants even. We need to look at these medications. We need to look at metabolic monitoring. We need to be on top of it. It's really important. ECGs every 12 months. And also ask the young person, ask the client, ask the older person, have you had metabolic monitoring done? How often do you have it done? How about we do it now? How about we measure you and weigh you? All this information is valuable because not only you have a baseline to work from, but you can monitor over a 12 months period. Has there been excessive weight gain on that particular psychotropic medication? Has there been increase in blood pressure? Are they showing other symptoms that we need to look at, that we need to bring to the attention of the GP and say, look, doctor, we've noticed 20 kgs weight gain in 5 months. Now that is quite excessive. So we need to be on top of this in terms of linking the physical health presentation in front of us to what is happening from a mental health perspective in the background. We usually will work very closely and try and link these consumers with the primary care provider, which is the GP. In that model of care, that shared model of care, we will always look at developing a care plan that the GP can follow, that recommendations, interventions that the GP can take on board and work with. As a practice nurse, you really need to be on top of it. You need to know, okay, when, for instance, Mr. Smith comes in 2 weeks' time, I need to do some metabolic monitoring. We will usually work with the GP with the consumer's consent to share information. Okay, doctor, look, he's due for his depot in 4 weeks. He had the last depot. He didn't turn up for the depot. He did turn up for the depot. He had a side effect of the depot. So these are the sort of communication that we as mental health clinicians always do with the GP. If we can identify a person that is at risk of developing a serious physical health concern, we will straight away make provisions to link them with the primary care providers. I'm not sure as practice nurses whether you do get any clozapine clients. For instance, clozapine is quite serious psychotropic medication. There is a clozapine clinic, and I'm sure most of the clients go to the clozapine clinic. However, there's also some clients that are being looked after by the GP. As a practice nurse, it's really important for you to know about the clozapine and to know what do I need to look for. When you do an ECG, for instance, if you have the facility to do an ECG, look at the ECG. If it's any different from the last ECG, bring it to the attention of the GP and let the GP alert him to the fact Mr. Smith is on clozapine, for instance. Other psychotropics, you know, like, I don't know, it doesn't, Seroquel or olanzapine, for instance, any of these psychotropic medications, please bear in mind that metabolic monitoring is quite important. There is a slide in here that's missing. I've attached a physical health screening examination form. I'm not sure if it's coming up on your presentation or not, but I'm more than happy to send it out, and I apologize for this. It is on the one on my hard copy. As a mental health service, when we first get the young person in, we, at the very first point of contact, we offer them or we give them a physical health screening form. That physical health screening form has got a cover letter with it. We ask them to give it to the GP, and the cover letter explains to the GP what they need to do with it and then how to forward it back to us. This physical examination form is really, really important. Why is it important? Because it gives us a baseline, tells us as a service a baseline of where the client is sitting from a physical health perspective, but it also acts as a baseline for the GP. Once we finish the episode of engagement with the young person, whether they did see a psychiatrist and get some medications on board, we will notify the GP. The GP can then continue the follow-up. So that physical examination form is really, really important. So when you see a client coming in with that form, you will know he's come from the child and adolescent mental health and why we send that form. It is part of partnering with the consumers and making sure that the physical health is as important as the mental health. Okay, so what do we do as mental health clinicians? That's also possible for you nurses as practice nurses. What are the interventions that we do that would promote physical health in mental health consumers? We always do education with the young person around smoking. We explain to them the dangers of smoking. We explain to them about sedentary lifestyle, need for exercise and some active engagement around. Education around substance misuse. A lot of the young persons that come to us, they either smoke cannabis or sometimes vape or sometimes use other substances like alcohol or ice or other illicit substances. We will talk to them about the impact of substances on their mental health. As a practice nurse, you can also provide the education around the impact of substances on the physical health. So this way we have the correlation between the physical health and the mental health. We always talk to the young person about nutrition, food choices, polypharmacy, taking medications that are not theirs or taking the medications the wrong way with not the correct indication. Side effects of medications, we always talk to them about that. The same thing can be done with a practice nurse. You can talk to the young person about it, explain to them, all right, this particular medication, you need to take it in the morning because if you take it at nighttime, it will cause you to stay awake. But if you take it in the daytime, it will help give you some energy and some pep to get up and get your day going. We usually talk to them about risky sexual behavior and sometimes about sexual health, but really not too much. That is very much a domain of the primary care provider, practice nurse, or a GP to talk about sexual health and sexual behavior, risky sexual behaviors. Of course, dental and oral health, we talk a little bit about it, but again, that's the domain of the primary care provider. All right, I'm going to briefly touch on this, but Michelle is going to talk to you more about it in depth. So those consumers I spoke about that are experiencing first episode psychosis, they will come to your practice usually on a monthly basis or 6 monthly basis, depending how often the GP wants to see them. How do we work with these people from both, again, the mental health and the physical health? We have to have that ongoing physical health screening. So I'm not saying do metabolic monitoring every time the client comes over. However, a set of obs, really important. Weight and height, really important, especially on a monthly basis. That's really important. Through this, doing this physical health screening, that will give us the best evidence-based intervention for keeping the mental health on track. Because if we notice excessive weight gain, especially if it's a young person, we know what that will do to the body image concerns. They feel, that will increase their anxiety. They don't want to go out because they feel they're too fat or they're too thin or whatever other issues it comes with them. Physical health is really important too, because it will give us, again, that very early indication of any side effects for the medications. So if we notice sudden weight increase, if we notice that the blood pressure is fluctuating a bit over the baseline, if we notice this person is got other symptoms like shaky legs or maybe with the clozapine excessive salivation, this is really important because we can then alert the GP, and the GP in turn can always talk with the mental health service and say, look, this is happening with the young person. Once we do this and we partner in this way with the consumer, we're able then to give them the chance to do an informed choice. We give them the information about alternative issues, alternative medications. We talk with the GP about it. But the most important thing is you then will be able to follow the pathway to refer that person to the right service. If the person is not linked with a mental health service and you're noticing these things, that's the opportunity to then talk with the GP to do a referral to a mental health service, whether it's the adult team or the child and adolescent team or the older person's team. Finally, the very first step in reducing physical health disparities in mental health consumers is the adoption of evidence-based lifestyle interventions. So really the emphasis in here is lifestyle interventions as a standard component of healthcare. So it has to be the main thing when we see a person coming into the surgery, a regular client, that we know they have a mental health component. It is really, really important. I can't stress enough the emphasis on having the physical health covered. I hope I've just given you a little bit of information about the importance of physical health. What I would like to do is, Michelle and I, we're sending out a survey. We sent a pre-survey. I've got a few replies. We're also sending a post-survey. If you guys can complete that, but we also would like to hear from you, nurses, practice nurses, through the PHN or through myself or through Michelle. What else support do you people need? If at any time you feel you need to talk with me, my mobile number is on Health Pathways. Don't hesitate. Just give me a call and say, look, Olivia, we've got this client. He's not linked with the mental health services. We feel this is happening or that's happening. I'm more than happy to talk with you on the phone. I'm more than happy to offer you the support, and I'm more than happy to give you the correct pathways on how to work with that client or that young person. Thank you again, everyone. Thank you very much for attending. I hope I was helpful. I will leave you now with my awesome colleague, Michelle, and she will take over from me. Hi, Mel.
Hi, Michelle. We just can't hear you. That's it. Now we've got you.
Oh, sorry.
Perfect.
Yeah. So I'm presenting on so early psychosis or pre-psychosis really, and suicidal ideation, sort of the type of young people that may present to general practice. So why I'm presenting this topic is because general practice is more often than not the first port of call when people have any concerns, whether it's physical or mental health concerns. So quite often people who are at risk of presenting with psychosis present to usually the GP with some kind of functional decline, some kind of mood disturbance, usually depression, anxiety, and quite often some kind of drug use. So when someone presents, they might present to you as someone who's declining in, or their personal care has declined a bit, they're more withdrawn, not socialising like they used to. The school or work performance might be declining, their relationships, either at home or with their peers, is declining, or they're having difficulties with that. And quite often they can present with fluctuating suicidal thoughts as a result of that. So these sort of things can highlight the possibility of someone that may transition into psychosis later on. So, and these are the symptoms that when you look back on the history of someone that has developed a psychosis, with hindsight, we would have said that this is what Olivia said before, the prodromal kind of phase. And this is referred to as the ultra high risk phase. So when people present to the GPs, they're more often in a much better clinical condition than, say, if the psychosis, they transition to psychosis and then psychosis worsens, and then they present to other ED or come through the mental health line kind of thing. So the GP practice is the ideal area where you can identify some of the risks and hopefully treat them a bit earlier and help so that they don't transition into psychosis. So some of just a few facts around that is the mean time between the onset of symptoms and someone actually seeking treatment is can be from 1 to 2 years. So this period of untreated psychosis, the longer that goes on for, is a higher risk factor of poor outcomes. So we look at trying to reduce that duration of untreated psychosis to reduce the severity of the illness and hopefully prevent someone transitioning into psychosis.
Michelle, I'm just going to interrupt you for a second. We're still on the first slide. Were you moving forward? Yeah, that's okay.
Yeah, I'm a technical whiz. Can you see? It's stuck.
Okay, that's okay.
Can you do it from your end?
No, but what I'll do is we will have a copy of it available in our education library. So yeah.
Okay, sorry about that.
Yeah, it was fine in the practice run. I think it's this storm,
yes,
maybe.
Isn't
yeah.
It?
Okay.
Okay, I'm sorry about that, but yeah, so it will be available for people to look at after. Will I just continue on?
Yes. Yep.
Yeah. So generally speaking, about 3% of the population do experience some kind of transient psychotic episodes throughout their lifetime. But it's worth noting of this, 75 to 90% of that cohort, it's a trend. They transition through that. The psychosis disappears over time, and they don't relapse or have another psychosis. So we're talking about a very small population that actually develops a psychotic disorder. When we talk about early psychosis, it's the period retrospectively that I just talked about, that prodromal kind of period, the ultra high risk, and it's considered to go through to a period of up to 5 years from the person entering into treatment for their first episode of psychosis for 5 years. But on the Central Coast LHD, our early psychosis team will see people from the time they're admitted for 2 years after that. So some of the risk factors around psychosis are 10 to 25% of people with first episode psychosis also report deliberate self-harm or suicide attempts prior to treatment. They're much or 4 times more likely to have committed violent offences, and that's quite often because of their psychosis has been untreated. There's a significant correlation between the duration of an untreated psychosis and homicide. 34% of people with first episode psychosis have experienced in their lifetime sexual or physical abuse, bullying, family violence, running away from home, childhood sexual assault, physical abuse. So significant trauma in the earlier life. And 16 to 25% of people with schizophrenia have reported being victims of crime at some time in their life. So they're quite vulnerable population as well. So that prodrome period, or the ultra high risk period I told you about, is the period where the people are most likely to present to the GP with symptoms of depression, anxiety, So maybe they've just got a bit of a lower mood, they're not enjoying things as much as they used to, they might be sleeping a lot more or a lot less than they used to. And this is quite often coupled with substance use. So for someone that does present with these sort of symptoms, and I'll go on to talk about in a minute how that can be managed somewhat by a GP practice and quite often by us as well. So with symptoms like that, it's using antidepressants is quite helpful, but also some form of cognitive behavioural therapy works quite well in conjunction with that. So when someone's presenting to a GP, there'd be, in this circumstance, referral, you could consider referring to a private healthcare provider for some therapy. Also, omega-3s have also been proved to help people not transition into psychosis. When we're looking at this population, we don't tend to use antipsychotics at this stage unless there's overt symptoms of psychosis for at least a week, except for if there's a higher risk of aggression or self-harm. And again, that might be something that a referral to the mental health service is worth doing, or a referral to ED. When we're looking at antipsychotic medication, we do start low and go slow, because people with the first episode psychosis respond to much lower doses because of their biological sensitivity. They respond more rapidly. And so we look at this when there's a worsening of psychotic symptoms or a deterioration in functioning that's not able to be treated with antidepressants and with therapy. So some of the antipsychotics you might use are the second generation antipsychotics like amisulpride, aripiprazole, quetiapine, risperidone, trazodone, and clozapine. We tend to try at least one other medication before we use clozapine because of the physical risks. One medication we tend not to use is olanzapine because of its metabolic profiling for the person. If we do use them, we use low-dose antipsychotics, and we always use some kind of cognitive behavioural therapy that can work on the symptoms of psychosis or the symptoms of anxiety and depression. So antidepressants therapy is associated with lower rates of transition to psychosis than actually using antipsychotics, so it's definitely the preferred first line. And omega-3 fatty acids to reduce the progression to psychosis. When we do use medication to treat someone, we look at that continuing for 2 to 5 years after they first experience their symptoms, just to make sure that they can transition back into using therapy and transition back into their life, whether that's school, work, and resume their hopefully pre-morbid state. With the YIPI, we will, like I said, our early psychosis team, we will see people for up to 2 years after they're first with us. So just to summarise, when someone does present with these sort of ultra high risk to a GP, we look at, so first line would be antidepressants to treat the anxiety, depression, referral to drug and alcohol services if the person's willing to reduce their substance use, and also cognitive behavioural therapy or some form of psychotherapy to work on their symptoms and their mood. Other presentations that may be more common to the GP practice from a young person's point of view is suicidal ideation. Suicide, just a few facts, suicide is the leading cause of death due to injury in Australia. Most people who die by suicide do so because of overwhelming and unbearable psychological distress. But we do know that if people are safely helped through this period of high risk, that they usually do recover to their former equilibrium. A significant proportion of people who die by suicide have had contact with a health professional weeks prior to that. So this will quite often be to the GP or to the ED. For everyone who dies by suicide, it's estimated, this is from the Australian Bureau of Statistics, that about 20 more people have attempted to take their life. So some of the known risk factors around that, and these are things that might be highlighted when a person comes to your practice and tells their story to you. So on an individual sort of focus, the history of suicidal behaviour, major physical or chronic illnesses, chronic pain, mental illnesses or unrecognised or untreated, and I touched on that with the psychosis, drug and alcohol misuse, a history of trauma, abuse or neglect, quite often low socioeconomic status, restricted education achievements, family history of suicide, a sense of isolation, feelings of hopelessness, helplessness, and impulsivity. Some of the situational factors around risk of suicide, family breakdown, job and financial losses, long-term unemployment or not attending school, stressful life events, breakdown in relationships either in the home or like with the young people, quite often that's breakdown in their relationships with their peers, bereavement, loss of a loved one, transition from school, hospital care, correctional facilities. Quite often we will have presentations from young people that are stressed with a HSC. Homelessness or being risk of homelessness is another factor, and easy access to means and of suicide. So I'll talk about that a bit more in a minute. Other factors are social or cultural factors, so exposure to suicidal behaviours. That's quite common for the young people that we see that have experienced their friends either suiciding or have witnessed suicidal behaviours within their peer group. The barriers to accessing health, so particularly mental health, people might not know how to access mental health, might be too embarrassed to seek help. Social isolation or lack of social support, so feeling really isolated. Culturally dislocated, for example, the Aboriginal community from their culture. Inappropriate media reporting, so social media, bullying via social media, that kind of thing, which has a big impact for our young people. Some of the historical risk factors are childhood abuse and neglect, trauma, suicide bereavement, so friends or family that have suicided, death of a parent early in life, bullying, and grief and loss around cultural identity as well. So some of the triggers for the person might be the impact of the mental illness or their symptoms, and I talked about that with that prodrome presentation of some of the anxiety, depression, loss of functioning, so the impact on that. Lack of professional support, so not seeking or not knowing how to seek professional support. Interpersonal relationships with peers, partners, friends. Also, for some of our young people that identify school as a safe place, home might be a stressful place to be, and some of our young people find school a safe place. So we're looking at then during school holidays, that's a higher risk for them because they're at home. And opposite to that is children that have, for many different reasons, school refusing. So that might be because of bullying or not wanting to leave home because of worrying about their parents or worrying about some family issues. So returning to school for them can be a significant trigger as well. So when you get someone that's presenting with suicidal ideation to your practice, just some of the, obviously, if you're very concerned, you ring the mental health line or have the person present to ED. The things you might look for yourself in your practice are any specific plans that the person might have, any access to means. For example, if their plan is to drive a car in front of a tree, do they have a car? Do they have access to a car? If they don't have access to the car, then that might be make that risk a bit lower than if they've got a car and they drive all the time. The potential lethality chosen, persistent ideation. Some people have chronic persistent ideation, and sometimes that might look like that, well, they're always feeling like this, so the risk is a bit lower, but we can never be too sure. At some point the person may, you know, their chance of trying to suicide will increase. Precautions, what precautions have they taken against discovery? So some people might plan very well to go somewhere where no one will find them to suicide, so that plan would seem a lot more dangerous and lethal. Other people, not saying that they are less at risk, but some people might take a lower dose of an overdose at home where someone might find them, so that chances of being found are higher. Their impulsivity, just getting an idea of their impulsive thoughts. So someone that's got chronic suicidal ideation and presents as quite impulsive or has a history of being quite impulsive, that can increase their risk as well. Also, just asking about any details of previous suicide attempts. Also looking, when working with a client, if we're looking at a safety plan, so asking them, perhaps in the case of our young people, their parents to put away knives, put away the access to means for them, mind their medication. Just looking at the likelihood that the family as well as the young person can follow the treatment, the safety plan. If we're confident that they are willing to engage in a safety plan and the family has the capacity to help with that, then we might look at, okay, they'll be safe to go home. But if those things aren't there, then we have to look at, is a person actually safe to be at home, or whether they might need somewhere like hospital to go. When we do look at someone presenting with the risk factors, we also look at their protective factors, so things that might keep them safe, and the more protective factors they have, the safer they potentially can be. So feelings, so protective factors like feelings of hopefulness. So sometimes our young people have feelings of wanting to die or feelings of I've had enough, but they also have a hope for the future or some plans for the future. Someone with another protective factor is positive personal relationships, a sense of purpose, a sense of hope, social acceptance, so someone that has a good peer group or family connections, people that are help seeking, so have these feelings but do present for help, people that have the ability to adapt to change, the ability to recognise stressful situations or work through stressful situations, people that have problem-solving skills. Sometimes a protective factor is parents who they feel comfortable to talk to, a safe teacher at work to talk to, at school to talk to, a sense of purpose. For example, yesterday I was talking with a young person who has chronic suicidal ideation and some self-harm, but is in her 3rd year of a uni degree and has hope and plans to finish that degree and plans to work past that. She's got a couple of good friends that she sees quite regularly, 2 best friends, and she planned to contact them the next day, and they were going to do some social things. So having those sort of future plans, even though they have these thoughts, is very positive as well. So just to highlight for people that may present to you, if there's a time where you feel that the risk is too high or that you're not too sure about whether the person, you know, can stick to a safety plan or is not going to be highly changeable, it's more than welcome to present them to ED or ring the mental health line and refer to mental health to follow up. Yeah. So that's the end of the presentation on just early psychosis or what you might look for when someone presents to the general practice. So I think I'll hand over to the next presenter now, and I'll hang around for questions. And my apologies again that the presentation didn't come up. So I think over to Erica.
Yes, thank you very much. I'm just checking that my PowerPoint's working okay, Mel.
Yes, looks great. Thanks, Erica.
Excellent, thanks. I'll kick off. Okay, so yeah, I'm just presenting on the health pathways that we have that relate to youth mental health. So I'll just pop over to the next slide. So these are the login details for the Central Coast Health Pathways website, which is available for local health professionals, the website and the login details. And then we also have a companion website called Central Coast Patient Info, which is open access for the whole community, for patients and clients, and that's at ccpatientinfo.org.au. So patients can find that, and there's no login details required. So just a quick overview of what Health Pathways is. So Health Pathways program is a systematic way to improve care between the sectors, between primary, secondary and tertiary care. So the website is an online decision support tool that GPs and practice nurses can use during practice consultations with patients to quickly find information that they need to support patient care. And it provides locally agreed information on how to assess and manage conditions and how to refer patients to local services. And then agreement and clarity on accessing services, who provides the services and where and when they're provided. So this is just a screenshot of the homepage. That's what the homepage looks like. All right, so we've got quite a lot of health pathways related to mental health now, localised. So the login details are there, and then on these slides, these are all hyperlinks. So if you're looking back at the presentation on our website in the education library, that will hyperlink directly to each relevant pathway. So quite a lot of mental health related pathways localised, as I said. So just some examples there. So we do have anxiety and depression in children and youth pathways, OCD in children and youth, ADHD and ADHD medications, a youth mental health specific page, self-harm page, suicidal ideation and intent, eating disorders, psychosis and medication related to psychosis. Also physical and mental health. So as Olivia talked about, the physical health components that we need to look at and monitor and look after in people experiencing mental illness. We've also got a summary page called Mental Health Stepped Care, which summarises the policy of stepped care from very low intensity support, such as phone helplines, right up to the acute stage 5 care and all the transitions between. There's also a page that's recently been reviewed and updated by our GP clinical editor, which is scheduling and compulsory care aspects. Also some out-of-home care information and child abuse and neglect. Okay, just trying to load to the next slide. Oops. So referral pages. We also have quite a lot of referral pages specifically related to mental health. So we've got information on if patients need urgent mental health assessment, what are the options for general practices referring for urgent mental health assessment. Also access to psychiatry, so the local psychiatrists, private and public, and also a couple of private online psychiatry practices that do telehealth. if you're having difficulty getting your patient in to see a psychiatrist in a timely manner, that may assist. Also, child and youth mental health assessment specifically, and then psychologists who focus on children and youth specifically. We also have the community mental health support page. So that's the non-government organisations, charities that provide that non-clinical, maybe the social supports, support with education or housing issues, maybe family relationship type counselling to improve family dynamics, those sorts of charities and non-government organisations. The online mental health therapy for children and youth. So a lot of CBT programs are available now online. So those can be quite helpful if patients would prefer to do CBT programs online rather than face-to-face. And information about accessing the funded psychological services. So the PHN commissions local providers to provide subsidised psychological services for special needs groups or vulnerable groups. That's not through the Medicare system, so there's information about how to refer through that system. Referring for eating disorders support, so psychology, dietetics, and so on that referral page. We've also got a summary page of all the mental health helplines, also the advice pages for professionals just wanting phone advice from mental health providers. And we've also got some new pages such as the social prescribing support, which is again that sort of social support services that might assist people who are isolated, for example. Sorry, the slides are a little bit slow loading today.
There's been some wild weather I'm hearing up north. This might be affecting us, I think.
Yes. There we go. All right. So hopefully the audience can see this by now. It's still loading quite slowly for me. All right. So this is just a screenshot of the patient info homepage. So practices are welcome to provide the web link to patients, ccpatientinfo.org.au. We also can send out business cards with that address on it, and on the other side, GPs and nurses can write the specific diagnosis that the client has received, or what information you'd like them to look up on the website. So we can post those out. Just contact myself through the Primary Health Network, and we can provide those cards to you to pass on to patients. And this is all reputable information that's been curated by our team, including our GP clinical editors. So it's reliable, reputable information. We link to peak bodies, helplines, phone lines, local services. We have some brochures and information about local services and lots of links to reputable peak body websites. Just loading the next slide.
I'll just mention as well that I've popped into the handouts the presentation that Michelle had, so it's available there if you click on the handout component, and I'll also email them out to you as well for all attendees.
Thank you.
Right, thanks, so this is just how to contact the Health Pathways team. So our email address is cchealthpathways@hneccphn.com.au. So that's how you can contact us. We always welcome feedback on the pathways, the referral pages. If there's anything that you'd like added to Health Pathways, if you'd like a pathway localised, we always welcome feedback either through our email address or the send feedback button, which is at the top right of each page on Health Pathways. And you can also just click on in the top right corner on the Contact the Health Pathways team page to get in contact with us to send feedback. All right, that's the end of my presentation. Thanks, Mel.
Thanks so much, Erica. I really appreciate it. And like I said, apologise for the tech issues this evening. Hasn't happened for a long time. We've had a good run, but sometimes these things are out of our control, so I do apologise. I have popped, it is now in the handout section of your little box there, so you'll be able to access it there. Also, it'll be available in the education library along with a copy of tonight's presentation, and I'll also email those out to all attendees as well. So I think we've covered all the bases there. And I just wanted to mention, if tonight has brought up any issues for anyone, please contact Lifeline on 131114. They're a 24-hour service a day and 7 days a week. So you take care of yourselves as well. I really appreciate everybody's time. Thank you so much for being here. Thank you, Olivia, for all the work you put into tonight's event as well in the background. It's very much appreciated. It's always lovely to work with you all. And thank you all for being here tonight, and for the attendees as well for your time. So have a lovely evening, relax and enjoy the rest of your night.
Mel, can we please remind everybody about the survey, the post the presentation survey, please? Thank you.
And asked us to send out some post questions, so we will be forwarding those around to all those attended as well, on top of completing the survey normal poll that will pop up at the end of this session. All right, so thank you, everybody. Lots of work goes on in the background for these events, and it's really appreciated. So thank you, and have a good night, everyone.
Thank you.
Good night.
Good night.